Do we have any questions from the audience? Does any questions or comments from the panel?
I just have one comment, actually. It's interesting. I loved the complication presentation, Rachna. I was at a journal club just last week with the authors, Katie, Shannon, and Jean, and we were talking about whether we should be teaching our colleagues how to do retrobulbar hyaluronidase injections, because so many people are injecting, and if the time limit's only 15 minutes, like, it's better that someone gets care. What's interesting is that I had 2 cases that were referred to me in the last year with visual change after a colleague or a cosmetic physician injected hyaluronin. And, you know, they were sent to me urgently for retrobulbar hyaluronidase. But when I examined them, one was actually a retinal hole that the patient probably had, you know, but didn't even recognize and notice it. And then when the physician actually had done the fillers, noticed, oh, there is some visual changes. And so without the examination, you know,
that's the
big
debate, right?
point, right? So
because for the non-ophthalmologist, there's an, so we talk about, should we train the non-ophthalmologist to stick a needle behind the eye? Well, the first thing is they have to know how to diagnose and make sure it's CRAO, which I don't know that everyone has tools to do. But, you know, so if they stick a needle behind the eye and it's just maybe some blurry vision from dryness or something, and they puncture the globers. And so there's all sorts of issues to think about when that debate comes up, you know, should we teach them?
I think most dermatologists don't even have an eye chart in the office or an
Right.
Amsler grid, and you know those are things that we need to encourage them to have, just
Yeah.
so they have that baseline. Because I've been called up by dermatologists before that actually did retrobulbars, and I'm like, well, did you check the vision? Well, you know, they said they couldn't see so well. So-
Right, and they didn't include
exactly.
one eye,
that's exactly right.
Yeah, I agree. I think that we have to encourage them to have some assessment of the vision. That's the most
Right.
important thing. And refer on. It may not be 15 minutes. I don't think we have to stick to that number. You can see with that last case, it was 5 days. And we just need to have objective assessment and appropriate treatment.
Right, and if truly there is a central retinal occlusion, you're sticking a needle behind my eye, anybody, right? Because there's not much you can do. We have a question from the audience. Does anyone have any experience with Belafil? I do not inject it. So for the rest of the crew, Belafil is a permanent filler made of acrylic microspheres.
I don't particularly use it, except for acne scars with a specific request from a patient, but I've cut it out of a patient's forehead 10 years after it was injected. It caused very delayed granulomas because it's permanent. Their reps can only claim 5 years, but it is permanent. It's PMMA. So they teach 5 years even though it lasts forever, and it can activate 10 years later. And I have another patient who had it injected under her eye, and she has a huge nodule we showed in the slide the other day. And the interesting thing is it actually has a very low complication rate, much lower than any of these HAs. The problem is when they do have complications, over half of them are in the periocular area. There's something about the non-mobile area that causes the problems with that filler.
Yeah, I agree. I actually just recently, in the last month, was referred a patient who had Belafil placed by another cosmetic physician and unfortunately has developed granulomas around the tear trough area. And it's problematic, of course, to treat that. We're now using Kenalog and we're talking about 5-FU injections. So I think that it's a hard one to manage.
Yeah,
Definitely.
I would just like to add to that if we're going to use permanent fillers that we can't reverse and they do cause an embolic phenomenon, that's going to be a huge problem. At least with HA, they're little micro occlusions and potentially dissolvable. So I strongly encourage people not to go for the PMMA types.
Right, permanent or longer acting fillers also mean longer acting complications.
Right, exactly, and the face continues to age, so if you put something permanent, it's going to stay in different areas where the face ages. So real quick, and one more question and comment from the panel. What concentration of hyaluronidase do you use? Do you guys dilute? Do you not dilute?
So there was an elegant presentation at ASOP Press that was looking at different types of HA and concentration of HA and the amount of hyaluronidase used to dissolve it. And certainly products that are thicker, such as Voluma would require higher doses of hyaluronidase, and you can repeat it. So Claudio De Lorenzi showed quite well how you can give pulsed injections of hyaluronidase. I don't think the dose as such matters too much, but you can repeat. I would use around 1,500 if I'm dealing with a vascular occlusion.
If you have
Right. I think it depends. It's a good point. So it depends on what you're doing with hyaluronidase. Are you trying to sculpt maybe too much material? You know, some people get Tyndall in the tear trough, and maybe I will dilute it and try to shape it a little bit. But if there's a vascular event, I don't recommend diluting. You just take those vials and inject, keep your patient there until the tissues start to reperfuse. Any other comments? Thank you all for coming. Oh, wait, is there one more question? What fillers are you using for Bell's palsy and to rejuvenate hemifacial spasm?
Okay, so my experience is with the Juvederm range, and for Bell's palsy in the cheek area, I would use Voluma. I use off-label Volift in the tear trough area, what we actually see is that it causes something called myomodulation, and this is quite controversial, that actually you're using filler either above or below a muscle to alter the fulcrum and the vector. And so like lacrimal pump, where we're tightening an eyelid to improve the watery eye, you can alter the vector by injecting the filler in the appropriate plane to improve the muscle contraction.
And we're going to have to cut off questions very soon. I'll just do the last one. What do you clean the skin with prior to filler? Anybody?
I use stanhexidine, but I'm mindful because, of course, stanhexidine can cause corneal issues. But I use stanhexidine in my practice.
Yeah. So I'll just quickly. We published in Derm Surge looking at the effectiveness in vitro of hypochlorous acid versus povidone iodine versus chlorhexidine versus isopropyl alcohol. They all were very effective at eliminating normal skin flora. In this in vitro study where we just combined bacteria with these solutions and plated it, hypochlorous acid and isopropyl alcohol killed everything immediately. All 4 of them took 1 minute to kill MSSA, and chlorhexidine took 15 minutes to kill MRSA. We're now doing the in vivo study where we're actually swabbing skin, and it's showing effectiveness across the board with all of them, and it actually showing that chlorhexidine is effective as well. So that's just what we've...
Yeah, just one quick point in addition to that is that hypochlorous is very safe to use in the periocular area.
Right.
But it does smell. And so you're doing aesthetic treatments for patients, and you want the whole process to be pleasant.
Yeah.
So you go out smelling of chlorine.
Right.
Which is not ideal.
Yeah, I just use isopropyl alcohol. That's it. Anyway, thank you so much for coming.
Thank you.
Lovely to meet you.